My name is Alex Duarte, and I work at the University of Texas Medical Branch in Galveston. I'm a professor in the Division of Pulmonary and Critical Care Medicine, and today I'm going to provide you the results of our recent findings. Home oxygen is frequently prescribed to individuals with chronic obstructive pulmonary disease and hypoxemia at rest, as it has been reported to improve survival in subjects with chronic obstructive pulmonary disease and severe hypoxemia. 35 years ago, two multi-center trials reported substantial improvements in survival and quality of life with continuous oxygen therapy in the treatment of severe hypoxemia associated with COPD. Notably, aside from smoking cessation, no other medical intervention has been shown to improve survival for patients with COPD. Consequently, oxygen therapy to treat hypoxemia associated with COPD has been widely adopted by clinicians. In the U.S., oxygen is prescribed to an estimated 1 million Medicare beneficiaries at an annual cost of $2.9 billion. While the benefits of oxygen therapy have been outlined, the adverse effects are less well defined. The relationship between cigarette use and oxygen therapy has been described in various single-center case series. Estimates of the number of individuals who are prescribed oxygen and continue to smoke has been reported to be between 38 and 43% of individuals. Yet quantitative risk estimates of burn injury associated with home oxygen have not been reported. In our study, we used a 5% national sample of Medicare beneficiaries. Between January 1, 2001 and December 31, 2010, we identified beneficiaries with COPD and burn injury based on ICD-9 revision codes. The risk of a burn injury in patients with COPD was performed using a nested case control and a retrospective cohort study. From January 1, 2001 and December 31, 2010, we identified 685 patients with COPD who sustained a burn injury and a matched cohort of 2,055 patients with COPD without a burn injury during the same period. We found that patients with a burn injury were more likely to have been prescribed oxygen in the preceding 90 days compared to the controlled subjects. In patients with burn injuries who had been prescribed oxygen, the face, head, and neck regions were involved in 54% of patients compared to burn patients who were not prescribed oxygen. At the end of the 22-month follow-up, the absolute risk of burn injury in patients prescribed oxygen was 2.98 per 1,000 patients compared to 1.69 per 1,000 patients for those not prescribed oxygen in the first 2 months of the calendar year. Risk factors associated with the development of a burn injury in patients with COPD included male gender, having 3 or more comorbidities, low socioeconomic status. Furthermore, patients who sustained a burn injury associated with home oxygen had a 10-fold greater mortality rate than patients with COPD and no burn injury. Prescribing oxygen to patients who continue to smoke is controversial. The ethical dilemma was reviewed by Lacoste and colleagues, who suggested not prescribing oxygen to active smokers who failed to comply with instructions, and to reevaluate patients discharged on home oxygen after hospitalization, as 1/3 of such patients no longer meet requirement for home oxygen. Likewise, the Veterans Health Administration addressed the need for informed decision-making in patients who continue to smoke and recommended use of non-coercive measures to mitigate the dangers of smoking and concomitant oxygen use. The majority of U.S. and European national agencies and respiratory societies request that healthcare professionals discourage smoking and recommend smoking cessation counseling. While countries such as England, Canada, Portugal, and Slovakia consider smoking an exclusion or absolute contraindication for oxygen therapy. Physicians prescribing oxygen to patients with COPD struggle to balance the benefits with the risk of fire hazard in patients who continue to smoke. In our retrospective cohort study, the number needed to treat to harm was estimated as a physician would have to treat 1,421 patients with oxygen therapy for 1 year to cause 1 burn injury. Thus, the benefits of oxygen in patients with COPD outweigh the modest risks of burn injury. In summary, healthcare providers should educate and counsel patients and family members about the potential risk of burn injury. Healthcare providers can also attempt to eliminate or mitigate this risk prior to prescribing home oxygen therapy.